Good afternoon everyone. I'm David Robinson, Lead Commissioning Manager for Urgent Care in Kent CCG. I'd like to introduce Mark Atkinson, who's Head of Urgent Care and Surgical Elective. We would like to spend a little bit of time with you this afternoon talking about our vision for an integrated urgent care. I guess the background to this commenced in September 2015 with IC24 being awarded the lead provider for a GP in A&E service at Maidstone and Tunbridge Wells, GP out-of-hours service and a home treatment service which hope to stop admissions to hospital. We see this next phase of development as stage 2 of our plans towards a truly integrated urgent care, working with GP practices, NHS 111, MTW and the community services teams. I think this redesign has been happening at a really difficult time for urgent care. The whole system is under pressure. We have reduced finances, increased activity, there is a depleting workforce, and these factors are most evident at the emergency department, where we see a huge increase in the numbers of patients attending. This is not just an issue for West Kent, but an issue nationally. Simon Stevens, the Chief Operating Officer of NHS England, expects improvement by September 2017. A number of national initiatives and effectively mandates to CCGs to deliver changes in urgent care, and you may have seen the recommendations within the NHS 5-year forward view, which describes every hospital having a comprehensive front door clinical streaming by October 2017, so that any departments are free to care for the sickest patients, including older people. Rollout of standardised new urgent treatment centres, which will be open 24 hours a day, 7 days a week, and they're really going to be integrated with all of the local care services. The Transforming Urgent and Emergency Care Primary Care Services describes the co-location of primary care services and out-of-hours services with emergency departments, providing the opportunity for collaboration and routine two-way transfer if patients need that emergency in the emergency department. We need to truly integrate the services, GP, community, secondary and the social care elements. Move on to the next slide. So what do we mean by urgent care? I think over the last 30 years we've had a confused system and various use of terminology. So my colleague here says in the 1980s, I wasn't around, so but my colleague tells me that there was casualty in the 1980s. We had accident emergencies in the 90s. In the year 2000, we moved on to urgent care centres, and then later we've moved on to emergency care. Our focus is on urgent and emergency care, and the slide just describes the definitions. A lot of urgent care, up to 80%, can be provided by your GP surgery or in the community. Same-day appointments, phone calls from GPs and home visits by services such as the home treatment service. So I think this is a confusing picture. We have Mrs. Smith there, she's at the top of the screen. Where does she go for her urgent care needs? Does she visit the pharmacy for a little bit of self-care? Does she contact 999? Does she contact 111? Does she go to her own GP? Does she wait until 6:30 and contact the out-of-hours service? The system, hopefully this diagram shows that the system is confusing and it's too fragmented, with a number of different handoffs between services. We don't provide consistent 7-day services for urgent care. Services are open at different times, and people aren't always sure where to go. Variation is a major obstacle. You might go to one place and receive something different if you go to another. And it's dependent sometimes where you live as to which service you get. So we've listened to the public, patients, the Health and Overview Scrutiny Committee and other key stakeholders and service partners at various engagement events. And this feedback has helped with the development of the new integrated urgent care model. Again, this just hopefully shows you the confusion. Multiple points of entry with various different branding, constant changes of names. Actually, do you know which services do what? The strongest brand, though, we think is the service in the middle, the accident and emergency, hence number of people attending. So the overall model of care has changed little, but medicine has changed a great deal. Delivery of care has changed, and paramedics and GPs can now do things in the home or in the back of an ambulance that the doctors did in A&E resuscitation rooms many years ago. Society has changed. We have a right now society, very different expectations, and also technology savvy. I can go online and order my Tesco shopping for 3 o'clock in the morning if I so wanted. It's the here and now that people really want. We also have an older demographic, more frail, more patients with dementia. It's now very common. So in 2012-13, so you can imagine that it's increased even further, over 1 million emergency admissions could have been avoided. 40% of patients attending A&E require no treatment at all, and only 4% of emergency calls are currently resolved over the phone. So, to summarise, the system is too complicated, too fragmented. People are not always sure how to get expert advice or where the best place to go. This means that a lot of people go to A&E or the emergency department as it's known because they know that they will be seen and treated. This means that people may be waiting longer in the emergency department but need to be there, and you may not be treated in the best place for your particular condition. I'd like to hand over to Mark now to explain how we're going to change things in West Kent.
Thank you, David. So I'm going to start by explaining what the difference will look like for patients, and as David has kindly alluded, there's a multitude of problems which we need to overcome. So I think first of all, we need to look at reducing the number of access points. So we're proposing that we would develop 4 access points. We'd strengthen urgent care provision closer to your home, and this links in with discussions that Dr. Sanjay Singh has just mentioned to you. And we'll also create 2 urgent care treatment centres, one at Tunbridge Wells Hospital and one at Maidstone Hospital, and they would effectively act as a filter in front of those emergency departments to see and treat patients. And would also enable a safe and prompt assessment and potential to escalate those patients, i.e. move them into the emergency department if they deteriorated. So we feel this is a safe, sensible process and provides a safety net for those patients that are attending the urgent treatment centre. We'd also like to strengthen some of those home treatment services, particularly those that help to avoid the unnecessary hospital admissions, so the home treatment service. There's also the Home First service, which would promote rapid, safe discharge and provide an element of care in your own home, particularly to those older and more vulnerable type patients. And we see that treating patients, especially those that are elderly, closer to home makes more sense and is effective and beneficial for the NHS, and also is a lot safer. This is where I wish I had an extra pair of hands. Okay, so these are the 4 access points, and I'm just going to quickly run through them. So first of all, we've got the GP surgery, and as David has already said, approximately 80% of urgent care can be or is being delivered within your GP surgery. But it would also be possible for your GP surgery to refer you up to the urgent treatment centre, maybe to be seen in one of the ambulatory type clinics. The second is the NHS, and this is probably our preferred route into urgent care, and that's because you'll undertaken a pre-assessment within NHS 111, and also in the not too distant future, we'll have the clinical assessment service as well. So this is adding to the current NHS 111 service, increasing the number of clinicians, i.e. nurses and doctors working within that service to help further assess those patients and reduce patients being sent to hospital or to the out-of-hours service. What we're hoping to do is to increase the number of consult and complete and increase the numbers of patients who they're sort of are resolved on that call. And then the next one down the left-hand corner, sorry, the writing's not very clear, but that's 999. That doesn't change significantly. So if you have an emergency, you dial 999, and an ambulance or a paramedic would come and attend to you. But it is possible during that examination by the paramedic that they decide that actually your needs could be also met at the urgent treatment centre, and you don't need to be taken to an emergency department or one of the networks. And then finally, the top right-hand side, as you look at it, is the self-presenting patients. So we're never going to be able to manage all of those patients. You're still going to get those patients who don't know the area, maybe they're not registered with a GP within West Kent, and they will attend the urgent treatment centre for their health needs. What we're hoping to do is that we'll use the NHS 111 pathways or the assessment process to stream those patients to see the right healthcare professional within the urgent treatment centre, and that might be any one of a number of healthcare professionals. Yeah, cheers. So this is the national picture, and it's not very clear, but there are handouts on your table. So we were describing the top three elements up here, but this is the national picture as well. So this is the urgent treatment. This is your traditional A&E departments, your EDs, your emergency departments, where you go if you've got abdo pain or other types of serious type injuries. And then we've got the real specialist care. So these are your sort of King's Hospital, and these are the patients that are transferred to specialist units if you're having, say, a heart attack or a stroke, or you've been involved in a serious road traffic accident. So you can see there's clear segments to urgent and emergency care. And then in the top right-hand corner, we've also put a little speech bubble which highlights the IT, the self-care, and some of those other enablers, things like pharmacy first, where you can be seen by a pharmacist and not necessarily by a GP. What I plan to do now is just to show you a very short video. It's only about 2.5 minutes long, but it hopefully outlines the national changes to NHS 111. So, any second now, we're going to roll video.
The existing 111 service comprises of calls coming in through the 111 system, where they are handled by a health advisor. Health advisors use a clinical decision-making support system and produce dispositions. Calls which are more difficult to handle as a result of complicated medical history or symptoms are handled by clinical advisors, nurses or paramedics. Dispositions are then passed electronically into the system. One of the problems that can occur is that those clinicians and professionals receiving the disposition lack confidence in their appropriateness. This results in patients coming back to the front of the system. Transforming to integrated urgent care means a single entry point for patients. Calls will be handled by a health advisor who will also be supported by a clinical advisor working as part of the clinical assessment service, also known as the clinical hub. Within this, there will be a clinical navigator GP overseeing patient pathways and a range of healthcare practitioners. There will be generalists and specialists such as mental health and paediatric nurses, pharmacists, and those who are experts in palliative care. Some of these specialists won't be based in the service's physical location. Instead, they will be available virtually from wherever they are working. These may be specialists such as transplant specialists, renal specialists, and cancer specialists. The relationship with 999 is very important and will see full integration with integrated urgent care, both in terms of being able to dispatch ambulances directly from calls coming in via 111, but also by being able to provide clinical support and advice from the clinical assessment service to paramedics and ambulance clinicians. Health and care professionals working within the community, for example nursing homes, can not only refer patients into the clinical assessment service, but can also get support and advice from health and care professionals. The Clinical Assessment Service will be able to produce an emergency department disposition, directly book appointments in and out of hours with GPs and other services. There will be access to specialists with video consultation for assessment and booking face-to-face appointments. For example, with a dentist, the mental health crisis team, a community pharmacist, or an out-of-hours primary care or GP facility. The Clinical Advice Service will also provide self-care advice to patients. Altogether, this is a transformed service which combines each element of the unscheduled urgent and emergency care systems for the benefit of patients.
There we go. Sorry about that. Okay, so just in summary, I think what we're describing there is a more intelligent system, a more intelligent NHS 111 with greater clinical input. And the doctors and nurses will have access to your electronic medical notes as long as you give consent to that. So they'll be able to see your past medical history and when you were last seen by your GP and a host of other really useful information which will help to make them make the appropriate and the right decision the first time. And then also what we're planning to see in the next year or so is an online version of NHS 111 which will again help to guide you through the health system. So the urgent care treatment centres, as we've already heard from David, many patients are attending with primary care problems and we're proposing 2 treatment centres working at the front door of the Maidstone and Tunbridge Wells hospitals in harmony with the emergency departments and patients who are attending with primary care conditions will be streamed using the NHS pathways, and the walk-in patients obviously will have go down the same pathway or algorithm. Now, if we find that your GP surgery is closed and you ring NHS 111, NHS 111 will be able to book you an appointment with the urgent treatment centre as well. And that's something that we haven't done previously, and NHS 111 has just sent you along to the emergency department without a pre-booked appointment. And for us, it makes it easier to manage the capacity and demand of the departments. And I think importantly as well, the key for me is it frees up the staff, the really useful resource and scarce resource of the ED clinical staff to concentrate on those with the greatest medical need. If we move on to the out-of-hours proposals, so we're proposing a phased approach, a change, starting with Tunbridge and the Cranbrook services. We've engaged, as David said previously, with the public in 2015 when we made the original changes to our urgent care service. And we had then suggested that we relocate the out-of-hours service from Tunbridge Community Hospital to the Tunbridge Wells Hospital. For whatever reason, that didn't happen. But we are proposing that we relocate those services, including Sevenoaks and Cranbrook. These are just the out-of-hours services. And the reason for doing that is that it strengthens those services, it consolidates that scarce workforce, and it's the most efficient use of the workforce that we've got within West Kent. And it also provides that consistent 7-day service across the whole of West Kent. And it aligns them to the emergency departments as well, and there's a whole host of benefits which I've already described as to why we would do that. Other things just to note as well is that Cranbrook sees a really small numbers of patients, and it's not an effective use of that GP resource. And on the back of this, there's been national money available to facilitate that change, and so we've tapped into that as well. The final slide I'd like to cover really is just the urgent care at home. So we've got 2 services within West Kent. We've got the home treatment service, which has been established for over a year, supporting and providing medical care to patients in their own homes. And these are particularly those patients who would be at risk of admission into hospital. So it helps and supports those patients in home. And in the future, we're expecting that service to be able to use the support facilities, the CAS, and the clinical assessment services to help and support and manage an even greater cohort of patients at home. And then finally, we've got the Home First, and this is developed really to maximise patients' independence when they're discharged. So they're fully supported at home, and it provides efficient, safe and effective discharge from hospital.